So we're going to welcome today Vicky Price, who is the co-founder of Peer Hub down in England, down in County Durham. I was really excited to meet her after looking at Peer Hub and looking at the website and hearing about some of the really interesting things they're doing. So welcome, Vicky. Really pleased you're here to join us today.
Hi, yeah, thanks. It's really, really lovely to be here, and I feel very flattered. And I hope that I can live up to the expectations of our website. But yeah, I think we do put a lot of stuff out there. We are quite committed to our values and what we're trying to do. So yeah, let's have a chat.
So I'm really interested, Vicky, about hearing what led you up to this point, because I think Peer Hub is a relatively new organisation that's been set up. So can you tell me a little bit about your experience and what led up to the development of Peer Hub?
Yeah, so I've been receiving psychiatric services from my teens and had like a really quite helpful experience a lot of the time. And I was diagnosed with severe mental illness in my late 20s. So like it took a while for me to get like really kind of, I don't know, like I guess what I felt it was like the recognition that there was something happening that wasn't right, that I was experiencing that wasn't right. But during my career, like I've worked in all these weird and wonderful places and got real opportunities. Well, I'm saying weird and wonderful in County Durham, like not worldwide, but like got some really interesting work experience. So I've been like a sound producer, a music engineer and performer. I've worked in solicitors' offices. I've worked in policing, not as an officer, but in the criminal justice sector. And I've worked in the NHS. And I've worked in like bars and I've just done this really weird, like my career trajectory went all over the place. And what finally led me to Peer Hub was this kind of feeling that we were missing something really fundamental about community in our healthcare services. So I worked as a peer lead in the NHS for about 3 years, designed services, worked in a business development role in the NHS, I've worked in strategic leadership type roles in policing. And I felt like it was really interesting the way that we would bring people through services as individuals, and that I felt that there was something really missing around community and relationships and bringing people together. Like I felt like people were being separated in their journey through getting help. So Peer Hub was about kind of bringing that back to our community. Like I think our communities have a lot of answers for people's struggles, and I feel like they're often disempowered by feeling like they don't have the expertise and that there needs to be an expert that provides help. So Peer Hub for me is very much about us as peers, as part of the organisation and also the community, like trying to figure stuff out for ourselves and having the confidence to work together to solve our community problems, including our wellbeing and mental health, rather than necessarily feeling like the first port of call is always to defer to mental health services. And that's quite a key theme in peer support. And it's interesting when you start trying to bring together the mental health services and peers, which is like why I'm really interested to have this chat today.
Yeah.
That's like one of the most interesting questions about existing services and peers, and then where user-led and community organisations sit alongside.
Yeah, that's really interesting. There's an awful lot of people that I speak to that are delivering peer that have had that variety in terms of their background that's kind of led them to this point. I know certainly Callum and his perspective is very similar to yours in this. Now, many of the people listening will be in this chat will be interested in developing peer roles. What do you think is the reason why an organisation should develop a peer role within their services, and what are the sort of key considerations that you would suggest to people?
So I guess like my entry into peer support came like around and about. So I started with a real lot of faith in the services that were already there, and then I was introduced to peer support and the psychiatric survival movement, mental health, human rights movements, like grassroots groups and mutual support and self-help. And I just found that knowledge absolutely fascinating in the way that they look at help differently. So I think the main thing that peer support offers us is like, so certainly for me in my, like from my experience of peer support, the first time I went to a peer support group as a member, I was absolutely terrified because I thought everybody who was in there was going to be absolutely bonkers, like real kind of like stereotypical mental patient type stuff. Like I was going to be sitting in a room with all of the stereotypes that I've seen on TV about what it is, even as I'm walking in there with somebody who doesn't see myself like that. And somebody came with me, I was so frightened to go. And when I got there, what I saw was people like me, and I was really like humbled, I guess, and I had to really check myself. And I think peer support for me is about that, like just the recognition of our humanity, and that how much of those stereotypes that we've internalized that we can then break down when we're sat around in a group full of people, and when we don't have to defer to somebody else to make a decision, or we don't have to. So for me, it's about tackling shame and self-stigma, this idea of what a mental patient is and what it means when you get a diagnosis, or what it means to be struggling with your mental health, and to really like humanize the experience of mental health stuff and have the chance to ask about things differently. And to be honest, for me, that transformed my experience of mental health services. So when I went to therapy after I'd been part of peer support, I was asking different questions. I was looking for different things. I wasn't necessarily relying on my expectations of what therapy was, because I'd been around a whole lot of people who'd been helped by therapy who were asking for different things to what I was asking for. So I think it's about tackling the shame of like, I'm just this horrific creature now that I've been labelled with a mental health diagnosis, regardless of how helpful. I found it really helpful to get a diagnosis. But then also that kind of feeling as though I could offer help as well as receive it, feeling as though I could see humanity in myself because I could see it in other people, like making us feel less like an alien and an outcast, and more like there was a place for us in community. And then also like, actually, I want to participate in help, and I want to get better for myself and the way that and how I'm seeing people get like change and evolve around us. So for me, it's very much about that community empowerment together, what we do together and how we see each other when we're together, rather than like what happens when we're on our own.
Yes, so there's a lot in there. There's a lot in there around the values of an organisation, and they're the types of things that can be considered. Now, I know Peer Hub runs peer training and also delivers peer networks as well. Tell us a little bit about the peer training, how that works, and what the key aspects of that are delivered.
So what we do around training. So one of the things when I was working in the NHS that was really difficult. So bearing in mind that the NHS wasn't set up like a peer organisation is set up, and it has like a very specific role as a care provider. And a lot of it is already sussed out, they already get it. So if you're going in as a psychologist or as an OT or a psychiatrist in a multidisciplinary team, most of the time people know what your role is and what you're doing. They had a real difficulty in understanding peer support because there just isn't that kind of, like, a lot of them assumed that they knew what it meant. A lot of the staff assume that they know that peer support is patients coming into the service to help other patients, and they're not aware of all of the knowledge in survivor communities or in local groups, or all the stuff that's been written about how peer support works and what it can offer and the skills. And when you bring in that to an organisation or to even whether it's a charity or the NHS or whatever, the main thing is to get across what peer support is. So when we deliver training for peers, the first chunk of our training is this is what peer support is in the community, and really digging into like what the values are, what it means to use your lived experience, how you might think about using your lived experience with other people, how you might negotiate relationships and how you might share power, the kind of democratic nature of peer groups and how they aren't led but they're facilitated communally, and the values-based and skills around that. And then we go for those when we're taking that then to an organisation like the NHS or a large charity that is based in multidisciplinary teams, and this is how you do that in this environment. So that they're really skilled and understand what peer support is, but also recognise that actually there's some things that you have to adapt to in organisations where the job that you take is in the NHS. So there's safeguarding processes. There's ways of applying for funding that look different, and that affects on what you'll be able to do and what teams you'll be able to work in. There's ways of thinking about risk. There's a lot of diagnostic language that might be difficult to understand. There's a lot of clinical language. There's a lot of responsibilities to your team and to the organisation. So then how do you create this peer relationship with somebody in amongst all of that? So that's what we help. And with the peer leaders, we help how we design that around, like, so if you are introducing peer support to an organisation, how do you look at peer work and look at what's already going on and bring it into the organisation with parity to what already exists? And how do you protect those spaces for peers to do really good peer work whilst also being able to fulfil their obligations to their organisation? So training is very much based around like the knowledge that comes from communities, stuff written by people like Sherry Mead or from the Human Voices Network, some of the great work that's going on in youth-led organisations in America, like the Wildflower Alliance, and taking that and saying, this is what peer support is. And then these are the things that you might need to think about if you're going to be delivering it as part of an organisation that isn't set up to deliver that.
And if you were an organisation that was looking to develop peer roles, let's say a voluntary organisation that was looking to deliver peer roles, what could you do to ensure that the support is there for those peer workers themselves? Because obviously it can be an emotionally draining experience. You know, you're listening to some quite difficult conversations and engaging in some quite difficult conversations. How do you as a leader make sure that the support is there to ensure that they can do their role?
So I guess there's like a few things. So the first thing is to, like, don't reinvent the wheel. There's already people out there who are doing this fantastically. Often they're user-led organisations, but they're already doing it. And I think a lot of the stuff that I was seeing when I was working with peer support in the NHS was people trying to create something for peers, where actually there's already some good examples of that. And also, like, not to overcomplicate what you've already got and try and create something new for peers. So we leaned very much into, when we were designing the peer support programme that I led, we've leaned very much into what already existed. So there was already expectations around training and preceptorship programmes. So how do you introduce someone to your organisation already? There was already systems around, like, supervision and management and wellbeing support was already there. So then how do we make sure that the peers have access to this in the same way that their professional colleagues would? And a lot of it was just making sure that those peers were treated with parity to their professional colleagues. But then you've got the additional burden on peers around using their lived experience. So I think there's a lot of, so what we've seen in England is there's a lot of misunderstanding about people being able to come into peer roles and know how to use their lived experience. So a lot of peer training here still doesn't include fundamentals on thinking about using your lived experience and the critical thinking around applying lived experience in the moment, thinking about what you're sharing with intention, not oversharing, because that's where a lot of the harm comes from, and being careful about reflecting on those very painful experiences all the time at work, like really trying to draw some internal boundaries around what we're connecting with and what we're bringing, and what happens when those boundaries like actually just overspill in the moment and you need to do something to protect yourself. So there's a lot around, like, don't just expect that people, because they've got lived experience, will automatically know how to use it, and look for good examples for training on how to bring your lived experience, and that will help minimize the amount of harm. And then, like, talk to your peers, speak to them about what additional support they need, because they're the best placed ones to tell you. But whatever you bring in around peer support, if you've got another staff group, so if you're not just a peer-led organisation who's just really doing lived experience work, if you've got another staff group, it's really important to share that learning across, because often the stuff that the peers are experiencing in the workplace, the staff are experiencing too. There's so many staff in mental health who've got lived experience, and peers get a lot of attention because they're outwardly they're outpatients, like they're not outpatients, but you know what I mean? Like, yeah, they're very open about their lived experience status, but you've got a whole load of staff who maybe aren't. And not to forget that those staff will also, whatever you're building for peers, try not to separate that workforce out, and remember that you've also got a whole load of staff that can benefit from the stuff that you're learning from peers. Otherwise, it can become a bit of an us and them. But why are the peers getting all that? Why do the peers get to spend hours with patients or service users or whatever, and we don't? Like, really think about not excluding those staff and groups from each other. So
it's really just about kind of communicating and almost practicing what you preach in terms of a peer role themselves. You need to do that as an organisation.
And not to panic about peers. Like, you've already got peers in your organisation. It's just they're not doing peer support. Like, you've probably in most mental health organisations, sometimes like 2/3, 3/4 of staff, the NHS staff, have lived experience. They just don't talk about it. So, like, for me, what the peers do, the practice and how you protect peer support and how you bring that in is really important. But it's really important not to divide staff groups based on who's got lived experience and who hasn't, and to really bring people together, because often people get quite frightened about bringing peers in. I've noticed this as like a nervousness. Well, what if they're off sick? Well, what if they've got convictions? Or what if they're not well at work? What happens if they don't understand risk processes? And in reality, most of the time, you've got people with lived experience working in your organisation already, that actually what you're trying to think about is introducing this new workforce that's going to use that lived experience in a particular way. And there's a map for that already. We've already got that. Human Voices Network, intentional peer support. There's a lot of work that the Scottish Recovery Network have already done. Like, it doesn't need to be a mystery and it doesn't need to be complicated. But you do need to pay attention to the difference and to make sure that, in terms of like the way that peers can be set aside because they're seen more like patients. So one of the things that used to come up often is you can't pay peers too much because then they're too powerful and they don't have a good relationship. Like, the power gap between service users and peers then becomes distorted if peers get paid a lot. And I'm like, well, that tells me more about what you think of your service users than what you think of your peers. Because actually, the more power a peer has in their organisation, the more power they have to share. So to be thinking more about the practice and really looking at the practice and how that's new, rather than treating peers that are coming in as different to the staff group that you've already got, because they're all like, their responsibility to the organisation is the same. Does that make sense?
Yeah, absolutely. I think it's you speak a little bit about the work you've done with small organisations, but I know Peer Hub does a fair bit of work with the NHS. Now, we know the NHS in England works differently to NHS in Scotland, and there's a different focus in terms of peer roles within the NHS down in England. I think they're actually targeted down there in terms of the number of peer roles. Yeah. I'm interested to get your perspective in terms of how that is working in the NHS in England, and how that kind of fits in with the national policy drives, and it's quite a different dynamic. So it'd be interesting to hear whether that's been a positive or.
Yeah, so there's some real positives about it. So like, it's funded, which is grand. There's money for peer support. I find targets a little bit, like, I'm not a target-driven person, even work in very heavily target-driven environments. I think they're very counterproductive. So we've got targets, thousands of peer support workers that people want in nationally. I don't think that's helpful for where peer support's at the moment. And the reason for that is I don't think people know what peer support is yet nationally. Like, they haven't done a very good job of defining peer support. So we've got peer support competency framework that's come out through Health Education England. And I think if you look at that, it's really difficult to see what peer support is from that. It looks like a lived experience support worker role. And I mean that respectfully to the creation of that. It's helpful to have competencies, but it just hasn't hit the mark for me. So I think that what we have got is a lot of backing. There's a massive community transformation process going on the NHS in England at the moment, which has masses of potential, really looking to work with voluntary sector organisations. It's got a large amount of co-production and peer support funding to it. But my worry about what we're doing in England is that with most people who are leading in that wouldn't be able to tell me the difference between a peer mentor or a peer coach or a lived experience support worker and a peer support worker and what those roles are. So we've got peer support worker roles in England that do control and restraint. And for me, that's like straight away, it's not peer support. It's something else, it's lived experience role, but it's not peer support. Like, that level of power imbalance doesn't work in a peer relationship. So that kind of like, what we've got is a massive funding, I guess, for lived experience roles, but I don't think we've quite nailed on yet. Nationally, the benefit of it being peer support rather than something else with lived experience. So there's massive work that can be done around peer mentors. So I use my experience to support you because you want to do things the way I've done them, and I can share that, and we can figure that out. Like, how can what I've been through help you? Versus peer support, which is like, what are we going to do together? And how are we going to learn together from each other? And how do our experiences help us create something different for us that then allows us, whether that's leading us into recovery or whether that's leading us into communities, or whether that's just getting the idea that, like, I am and I can and I want to be part of a community, that kind of shared responsibility part where it doesn't all, So I think that there's vast amounts of opportunities for lived experience work. But one of the things that I worry about a little bit is that we're seen as a homogenous group of staff, that if you've got lived experience, you're a peer support worker, and that actually we can really pull some skill out of the grassroots stuff that's been developed around peer support specifically.
Okay, that's really useful to hear your experiences. I guess sort of coming to a close, really, I just really want to understand from you, what would be your top tips, if you like, for an organisation that's thinking about delivering peer support within their organisation? Now, I know this is quite a generic question, but I think it'd be useful if there were 2 or 3 fundamentals that you would say this is something that you should consider.
Yeah, so I think peer leadership is important. So I think it's really important to have somebody who understands peer support leading, and that usually comes from someone, well, it should really come from someone who's done peer support themselves. They're running groups, they've had leadership role in a youth-led organisation. Like, I don't know, how do you define peer leadership? Like, I think it's a big question. It's quite difficult to answer, but I do think that it's really helpful if you've got somebody leading your implementation who knows about peer support and who has some experience of leadership. And then I think the other thing is, like I said before, don't reinvent the wheel, like use what you've already got. So if you've got a staff structure already, if you're a charity, for example, that already has like, this is what like a community support worker does, this is what I don't know, like a social worker does, this is what a manager does, like lean into that existing. And then the third thing is that use the peer knowledge, use what's already out there. There's loads of great resources that tell you what peer support is and how to do it really well. You don't need to reinvent that kind of, or like struggle to define what happens in the space between peer support worker and service user. That's where a lot of the stuff becomes confusing for peers and where the role fidelity starts to go. So one of the things that's happened in England that's very well measured and very well used is that if that space between the peer support worker and the service user looks like every other service relationship, it won't look any different. The help won't look any different. And peers won't hold fidelity to peer support values and peer support approaches because they're essentially doing what other people are doing. So the stuff that you put in between, like the relationship, I guess, between peer support worker and service users, I don't know what terms you guys use in Scotland, we use service users down here, to allow that to be shaped by lived experience, expertise from the groups that have been doing it for decades. Like there's good knowledge out there, you don't need to worry about that, we've got that. And people who understand peer support will help you with that. But if you don't protect that space between for the peers to do peer support, then they just won't do it. Like that's what we found in England. They just won't do it. It's what they found in America as well.
Yeah. I think one of the things that I'd probably add to that is it's probably not a big jump for an awful lot of organisations because they're doing it in part already, which is something that I kind of alluded to earlier. I think that lots of organisations are delivering peer roles almost by default because people will naturally come to organisations for support and connect with other individuals.
Yeah, and I think like if you're coming from a charity that's kind of going out of communities, like there's already a lot of overlap in terms of values and stuff. I think the real challenges are when you're coming from a perspective of an organisation that's been set up with like clinical structures and offering clinical help, because there's a tendency, because we know what good clinical help looks like from a clinical perspective, then they'll know what good peer support looks like, and actually they're quite fundamentally different. So when I'm looking for competency frameworks and stuff to help organisations, I'm not using health competencies, I'm using competencies from social justice and community development and places like that, because they've got a better, it's community-based work, it's not health-based. So it's just that kind of like being able to step back and just checking what you already know and where that comes from, and looking at the grassroots stuff and seeing, is that what we want to deliver? And if it is, being able to recognise that they're very different, but they can work beautifully together. Beautifully. They work amazingly together if you get it right. It's incredible. Some of the things that I've seen for people who've come through services where people thought that they were going to be in services for the rest of their lives, and they've come and worked with a peer support worker, and because it's different to what they've already received, it's unlocked that for them, and they've been able to create a new life for themselves. And it's not necessarily that doesn't happen. Like peer support isn't some magic thing that like everybody, it works for everybody. It's just that it's not in services as standard, certainly wasn't in England. And if you can bring it in, it unlocks help for so many people just because it's doing something that nothing else is doing in there. If it looks like what's already in there, you might as well just do what you're already doing and recruit people with experience for the role.
I think that's a really important point. It unlocks something, it unlocks that conversation, it unlocks that different journey, that road to recovery potentially, that clinical services can't necessarily do by itself.
Yeah. And often because of I think that peers have a really important role in translating reality back to services that have come detached from it. What shared language we're talking about. Like if I talk about depression, well, what does that mean? Everybody experiences depression differently. But if I talk about feeling like the world's too heavy for us to bear, that's a different experience to feeling like numb and that I just feel numb. And being able to translate that experience is really important, I think. And for a service user to be able to be seen as having that experience is like, oh, well, now we can get started, you know, as opposed to receiving help for something that isn't actually what's going on, which happens more often than I realised it did. You know,
I think that's a really, really powerful point to end on. So, Vicky, I thank you so much for coming along today. It's been really insightful, and I know there'll be other conversations that we'll have moving forward. So, thank you so much for your time today.
It's been brilliant. Thanks. Love talking about Pearsport stuff. Please come and see us at Peer Hope, man.